The second case we will introduce it by my colleague, Dr. Gaio.
Hi all. Can I have the slide, please? Just a moment. It's a case of a patient of a 13 years old female referred to our institution for an evaluation of a cardiac murmur. At the clinical examination, there was the cardiac systolic murmur, and also we found the low femoral pulse with a high blood pressure. At the echocardiography, we diagnosed an atrial septal defect about 13 millimeter at the transthoracic echo with a moderate overload of the right chamber, and also a severe aortic coarctation with, at the last echo controls, mild reduction of the left ventricular systolic function. She's in antihypertensive therapy with beta blockers, but the mother refused any treatment until now. This is the transthoracic echo showing the atrial septal defect with the left-right shunt, and also at the echo we can see the coarctation with the gradient across the isthmus and the holodiastolic runoff. So our intended procedure is to close the ISD and to stent the aortic coarctation.
We will decide to repair before the aortic coarctation in order to unload the pressure over the left ventricle, and then to close the ASD that is able to volume overload the left ventricle. So we imaged before the aortic coarctation. Can you show the angio, please? Okay, let's see. Go. As you can see, an aortic coarctation distal far from the subclavian artery origin. Then the next one. Quite discrete as a membrane far from the aortic, the subclavian artery. The measurement of this, the isthmus was about 5 millimeter, and the proximal part of the aorta, the transverse arch was 12 millimeter, and the aortic arch just proximal to the isthmus was 12 millimeter again. So we decided the segment could be covered completely using a CP stent 39 millimeter long bare metal stent. We normally use the covered stent in patient older than this age, and whenever the diameter of the coarctation is very tight, and the final diameter exceed 4 times the diameter of the coarctation. In this case, we have to put a stent that enlarge the isthmus from 5 to 12, and so we are quite confident that a bare metal stent could be enough. The length of the stent was 39 millimeter because it could resolve even a small hypoplasia proximal and distal to the narrowing segment. Now we put the long sheet. We used the 11 French long sheet, 63 millimeter long Mullins sheet to make possible to pass stent over a 12 ZMed high pressure balloon, 12 millimeter, 4 millimeter long, 12 millimeter in diameter. We introduce the long sheet, as you can see, and picture in picture with the fluoro, please. Larger picture and smaller myself, if it's possible.
La fluoro.
Perfect. Smaller one. Oh, don't worry. But okay, perfect. We cross the stenosis, and then we redraw the dilator. Put the wash. Okay.
Pompa il lavaggio, pompa il lavaggio.
Okay, we are almost ready. There's something wrong in the washing. Like, give me some water, please. Just to flush. Okay, now it's better. Thank you. On my hand, please. We crimped the stent over the balloon using the technique that Dr. Carminati showed yesterday, using a string for umbilical vein, and put the device inside. Then we're using normally a single non-bib balloon, a single lumen balloon. Now that used a smaller sheet. Now we perform an angio, please, just to see where we are. Okay, seems a quite good position in this one position. Just a little bit forward. Carol, could we use the lateral one? We have to put the lateral one inside. Could you, via l'eco, entriamo con la laterale. Mi date una mano a entrare con la laterale? Thank you. Stacca la transesofageo. Then afterward, we'll try to fix the atrial septal defect. Let's put the lateral in, please. Go ahead. Keep going. Okay. We perform another angio in left oblique view, just to position better the stent. I uncover partially the stent just to see the position. Could you show, puoi mostrarli la laterale?
No, ma in diretta.
Ah, ok. Aspetta, scopriamo un attimo. Just wait. Okay. Let's take another angio. Just a little bit forward. or not? Do you think could be a good position, this one?
You know, we were not able to see the lateral.
Yes.
So
Puoi far vedere la laterale? La laterale. Do you see the lateral one?
No, sir.
Did you see the lateral one? Non la vedono. No. Non so che dire. Falla rigirare. Facciamo we will perform the lateral after. It's possible to see the lateral or not? Possibile vedere la laterale o no? Sì o no? E qui? E quindi non lo può vedere. Ok, allora, we perform another angio, taking away the lateral and orienting the PA in lateral position, in left anterior oblique view. In this view, we show another angio. Do you think could be a good position, or I have to go forward? Just a little forward. Let's take another angio. It should be better, this. Don't you agree?
Yeah, everyone is happy here.
Okay, we uncover completely the stent. And then we perform another angio, just to be sure the position is not changed. Yes, I think we can deploy the stent in this position. Okay? Five, 8. It should be 12. The burst pressure is 10 atmosphere. We went up to 8, 10 atmosphere. It should be enough. Now we redraw the balloon inside the catheter and perform a angio. And then see if it's necessary to go up with the diameter. What's up? Wait a moment.
Are you doing another angio?
Yeah. Seems good. Or do you think it could be better to go up to... I think 12 is enough. because it's the same diameter of the preisthmic aortic coarctation. I think I'll move, I'll take the pressure and then I'll move away to the atrial septal defect. Don't you agree?
I think we have a consensus here, so we'll take a look at the ASD now.
Yeah, just to see the pressure gradient across. In ascending aorta, the pressure is about 110, and in the ascending aorta, pressure is almost the same. There is no gradient at all across the coarctation. Let's move to the atrial septal defect. We will show the transthoracic, transesophageal echo that shows a 8 millimeter large ASD in very anterosuperior position with a slight malalignment of the part of the septum, as our colleagues will show you. Carol, could you show them the clips? Ah, okay. We can perform on live. Part of the septum is normal, but in the upper part of the atrial septum, there is a malaligned part of the septum that is confluent with the left part of the aortic root. So we found it some time, and it's possible to close, but it's expected that the device could position in not regular way and just malaligned itself. It could be. We don't really know, but we should be prepared to this solution. The stretched diameter of this balloon, of this atrial septal defect, was performed by a Boston balloon dynamic evaluation, and the balloon plopped about at 11 millimeter. I think it could be better to put a slightly oversized device, and we choose to put a 12 Amplatzer device, and we hope that the right part of this device could be positioned in the usual way, but we are not sure of this possibility and should be prepared to other possible solution. Another possibility we tried to evaluate was to put a multifenestrated atrial septal defect that is more pliable than the normal ASD, but is not sure the position at all, and in our opinion could be more prone to embolize if the position is not good. It was impossible for us to negotiate the pulmonary veins, since the atrial septal defect has a funnel-like shape that make impossible or very, very difficult. We do not reach the pulmonary vein, so we decided to perform the either the sizing or the positioning of the device, lifting the guide wire into the left atrium. Now we take away the the introducer and put the delivery catheter. We put a 9 French delivery catheter, slightly oversized with respect to the size of the device chosen, just to be sure to redraw it if the position is not correct, is not satisfied. Let's put the video picture in picture and fluoro. Lavaggio. We cross with the delivery sheet the septum. We try not to go to the left atrial appendage. We leave the guide wire in the atrium and left ventricle. Okay. And then we put inside the emplazo device. To reach the correct position. As you can see, even the position of the delivery is quite oblique, despite a counterclockwise rotation from my hands. It depends, I think it could depend on the funnel shape of the ASD. Now I try to deploy the left disc, trying to deploy it where far from the funnel-like shape to avoid the entrapment inside the channel. Trying to maintain a quite it could be very difficult to align with the septum due to the as you can see is entrapped into the okay, I try to come from above just to free the okay, now could be better, but there is some part of the ASD the septum that is not entrapped into the device, so we can try again. We come back again. I think we have to open the waist into the left atrium. Oh, sorry. And then to come back, trying to entrap both components of the septum, but part of the septum is not entrapped at all, but it could be sufficient. Let's see the shunt. Let's see the shunt where that part of the septum appear. In some position it seemed well positioned and not dropping on both sides. In some other views it seems we're far away from the septum, but I think it could be well positioned. Don't you think so? What do you think about?
Have you any residual shunt, Pino?
Let's see. I think it's inside. I think it's inside the prosthesis. And I try to gently perform a to and fro maneuver, just to see if it's stable. As you can see, it doesn't move backward, and it doesn't move forward. Now we have to wait for the complete evaluation from the echocardiographer in all possible views. Please, Carol, do you? I think it's a good position. When you when you put the device, I think the position could be better. I will try. Devi aprire un po' di più. No, non è tutto aperto. Vai. Okay, don't worry. Okay, try to. Let's see the echo in different position. It seems good. Let's see for eventual residual shunt. Seems just intraprosthetic shunt. Seems good to me. What do you think about?
Looks good. Let's wait a little bit. Definitely relatively large with a deficient rim. And I think you have also a component of a small aneurysm of the atrial septum there too, that the aortic side legs were practically entrapped, but it looks pretty good.
Yes, I don't think it was an aneurysm at all, but it was a part. We sometimes we see a part of the septum that is the upper part, or sometimes the lower part, that is malaligned with the other part of the septum, and the insertion is not on the same plane of the majority of the septum length, but part of this septum create a small malalignment. Sometimes it's impossible when it's very large hole. We see very large hole with this malalignment. It's impossible to close the ASD, since the device put itself in very, very strange position, with the possibility of a late embolization. But we were lucky in this situation now, I hope. We have finished.
Great. Any comment?
Any comment to you?
No, excuse me. Why did you use the dynamic balloon for sizing this particular situation?
Yes, we normally use a dynamic balloon almost always, but in this situation, in my opinion, could be better because make you aware where is the real hole when the ASD has a funnel shape morphology, and you are able to see exactly what is the measurement makes the balloon plops on the other side. When there is a funnel shape morphology of the ASD, in my opinion, AGA or static balloon in general works worse than the dynamic stretch balloon.
Great work. 2 for 1, as we say. I wonder how you're going to charge her. 2 procedures, 1 procedure, but we'll leave this one to the insurance company. Anyway, thank you so much. Great job.
Thank you, Aki. See you.